Ultrasound guidance makes diagnostic bone marrow sampling safer and more precise. It allows accurate identification of the posterior superior iliac spine and central crest, facilitates optimal needle alignment, confirms cortical contact, and helps maintain the tip centrally positioned between the bony tables. This results in fewer failed attempts and cortical breaches, especially in patients with obesity or challenging anatomy, all without radiation exposure and using portable equipment. In this module, we will not revisit the technique for guiding the needle bevel nor the sterility measures required for the puncture, as these topics are covered elsewhere in the course. This presentation is primarily focused on identifying the posterior superior iliac spine and on the puncture technique itself. There are three main methods for posterior iliac bone marrow sampling. The first is the traditional landmark technique. This involves palpating and marking the posterior superior iliac spine and crest, then anesthetizing the area and advancing the needle centrally between the inner and outer tables. The second method is ultrasound-assisted marking. Here, ultrasound is used to locate and mark the posterior superior iliac spine and crest, but the puncture itself is performed using the landmark technique without real-time imaging. The third method uses real-time ultrasound guidance, allowing the needle to be visualized throughout the procedure. In the following slides, we will focus on this ultrasound-guided approach. When viewed from behind, the pelvis shows the iliac wings sweeping out from the sacrum like shallow shelves, each with an outer lip that can be felt beneath the skin and an inner lip facing the sacrum. The posterior superior iliac spine is located at the back end of the iliac crest, often beneath a noticeable skin dimple. Just below lies the posterior inferior iliac spine, while the sacroiliac joint line is found medially. The iliac crest broadens outwards and slightly upwards from the posterior superior spine, creating a cancellous channel that runs obliquely between the inner and outer tables. The posterior superior spine sits in close proximity to the greater sciatic notch and foramen, which provide a pathway for the sciatic nerve and the superior gluteal vessels. To locate the posterior superior iliac spine for bone marrow aspiration, use a simple surface triangle as a guide. The apex of the triangle is at the top of the intergluteal cleft on the midline. From here, move your fingers laterally and slightly upwards on each side until you reach the firm bony prominences of the posterior inferior iliac spines, which form the two lateral corners of the triangle. Begin pre-scan by placing the ultrasound probe transversely over the posterior superior iliac spine. Look for the rounded, superficial bright line of the cortex, which serves as your reference point. Medially, you may see the sacroiliac joint and the sacrum. Moving the probe downwards reveals the posterior inferior iliac spine, while moving upwards displays the thinner, more lateral part of the crest. These are real ultrasound images. The morphology of the posterior superior iliac spine may differ between patients. Starting from the transverse view, obtain an oblique longitudinal image of the iliac crest by rotating the probe approximately 40 degrees, so that the crest appears lengthwise on the screen. In our convention, the right side of the ultrasound image corresponds to the cephalad direction, or towards the patient's head. Move the probe medially and laterally to identify the medial and lateral edges of the crest. If you are using ultrasound guidance alone for the procedure, mark the center of the crest at this point. Because the iliac crest angles outward, it is important to align the needle with the bone's natural orientation during bone marrow aspiration. The puncture should be performed with the needle directed towards the anterior superior iliac spine, moving away from the sacrum. Typically, the needle is angled around 40 degrees laterally from the sagittal plane and about 40 degrees inferiorly from the transverse plane. This approach ensures that the needle enters the ilium correctly, avoids the greater sciatic notch, and accesses the medullary cavity safely. 11 cm stab incision over the most cephalad posterior superior spine to accommodate large gauge instruments. Longitudinal approach. Advance the bone marrow aspiration needle within the probe plane to the central cortical crest. A gel standoff or heel-toe maneuver helps steep angles. Transverse conformation. Rotate the probe 90 degrees to a transverse view and confirm the bright needle tip is centered between inner and outer lips. This reduces unintended drift to a lip. Enter the marrow space. With steady pressure and alternating clockwise, counterclockwise, advance the needle. Ultrasound cannot visualize the intramedullary path after cortical entry. With the probe placed in the transverse plane, begin by confirming the location of the posterior superior iliac spine. Observe the slope of the iliac wing to determine the correct angle for the needle. The most superficial point of the posterior superior iliac spine should be aligned with the medial edge of the ultrasound probe. Advance the needle in plane, keeping it visible throughout the procedure. The double-headed arrow marks the depth of the posterior superior iliac spine beneath the skin. In this patient, it is approximately 1.5 centimeters. Once the needle is positioned, proceed according to standard guidelines for bone marrow aspiration and biopsy. The order of aspiration and biopsy is not critical, as long as you maintain a minimum distance of 1 centimeter between the two sampling sites. The sciatic nerve and the superior gluteal vessels are the main structures at risk during posterior iliac bone marrow procedures, particularly near the greater sciatic notch. These structures lie close to the bone at the notch. The superior gluteal vessels are about 5 millimeters from the cortex, and the sciatic nerve is roughly 8 millimeters away. Injury can occur if the needle loses contact with the bone, is advanced too deeply, or if there is a significant angular error, even as little as 5 to 20 degrees. Such errors may cause the needle tip to exit the inner or outer table of the ilium and enter the corridor where the sciatic nerve and superior gluteal vessels pass, increasing the risk of vascular or nerve injury. To reduce the risk of complications, avoid advancing the needle more than 2 centimeters parallel to the bone, as this increases the risk of breaching the medial or lateral tables. Always keep the needle tip centered between the inner and outer tables of the ilium. Adjust your technique for each patient, taking into account body habitus and anatomical variations. Finally, ensure optimal operator positioning and ergonomics, as stable hand positioning and good visualization help maintain control throughout the procedure.